Okay, good morning, everybody. Okay, let's start. We're discussing about the management of impacted teeth. So during removal of impaction, you have to raise the mucoperiocial flap. You have to give the incision. Most commonly, we follow the modified Watts incision or Watts incision. Or better, you can give the envelope incision. In case of envelope incision, you don't have to give the releasing incision, so that the post-operative healing will be better. Okay. Once you raise the mucoperiocial flap, the next step is bone removal. The aim of bone removal is to remove the bone obstructing the pathway for removal of the impacted tooth. It can be done by two ways: by consecutive sweeping action using burr, and another method is by using chisel and osteotomy cut. So the question is, how much bone has to be removed while removing the impacted tooth? So bone should be removed till we reach below the height of contour where we apply the elevators. Extensive bone removal can be minimized by tooth sectioning. So most of the time we have to remove the bone till the cemento-enamel junction of the impacted tooth, the edge. So buccal guttering technique, whenever you are removing the impacted tooth, whether it is mesioangular or distoangular or vertical, that doesn't matter. You have to do the buccal guttering first. Okay. After doing the buccal guttering, then you have to section the tooth. So technique of bone removal, either you can use a chisel or mallet, or you can use the burr. The chisel is monobeveled, is a fine instrument for removing the bone, and the difference between osteotome and chisel is osteotome is bibeveled, and it is driven by hand mallet. So nowadays, commonly we use straight handpiece and micromotor ball. We don't use a chisel or mallet. During the COVID time, where we are not allowed to use an aerotor or a straight handpiece because it produces a lot of aerosol and the chances of transmission is very high. So during that time, we have to use chisel and mallet. So chisel and mallet is a traditional technique, old technique. Nowadays, we only use burr. And nowadays, whenever we are dealing with the HIV positive patient or a hepatitis B positive patient, or during the COVID times, during those times, we don't use aerotor or micromotor straight handpiece because that produces loss of aerosol. Another reason is we can't put our handpiece or straight handpiece or micromotor in the autoclave, so we can't sterilize the instrument. That's why in case of HIV positive patient or hepatitis B patient, we have to use chisel and mallet. We can't use the rotary instrument. You can't put all the rotary instrument inside the autoclave. It will damage our instruments. So we have to use chisel and mallet, and commonly we have to do all the surgery using universal precaution because of in case of the patient is HIV positive or they are hepatitis B, and we have a lot of HIV positive patients in Nepal as well. Okay. And the good thing is all the HIV positive patient gets free, all the drugs and free of cost from the TECU, and it is available all over our country, and it is available in all the government hospital, mostly in the zonal hospital. Okay. So whenever you are dealing with such a positive patient, you have to be careful. You have to do all the surgery using the universal precaution and never use rotary instruments because it may transmit disease to other healthy patients as well. So in case of chisel and mallet, this technique is though difficult. Using burr, it is easy. Patient acceptance is not tolerated when performed under local anesthesia. Using burr, it is tolerated well under local anesthesia. Chances of fracture of the bone is relatively high while using a chisel and mallet. If you apply excessive force, you may cause angle fracture of the mandible. So chances of fracture is less using burr. Healing of bone is good in case of chisel and mallet, but while you are using burr, it is delayed due to overheating and inefficient cooling, aggravated by inefficient cutting of bone, resulting in thermal necrosis. So while using burr, you have to continuously do the irrigation. If the temperature is more than 60 degrees, it will lead to thermal necrosis of the bone. So you have to prevent that. Post-operative edema is less while you are using chisel and mallet, and it is more while you are using burr. Chances of dry socket incidence is less with chisel mallet. It is very high using burr. Post-operative infection is less with chisel and mallet. It is more with burr, and disadvantage includes difficult to remove deeply buried impaction in edentulous jaw and impaction in edentulous jaw. In patient, the bone is thin, the bone is atrophic. Whenever you apply force with chisel and mallet, you may fracture the mandible. While using bore, it is relatively easy to remove deeply buried impactions in edentulous jaw and elderly patients. Have you seen chisel and mallet or no? No. No, after bone removal, you have to do buccal guttering. Then the next step is you have to do tooth sectioning. It is said that bone belongs to the patient and the tooth belongs to the surgeon. So it's better to section the tooth rather than to remove the bone, because anyhow you are going to remove the tooth. So no problem whether you take out the tooth in total or you section the tooth and you remove it in pieces. So rationale of tooth sectioning is to create a space into which impacted tooth can be displaced and hence removed. The indication are multi-rooted tooth with different lines of withdrawal. Most of the time there are two roots, mesial and distal roots. It's better to section the tooth. It is better to section the tooth and separate the mesial and distal roots. Sometimes the roots are fused. In such cases, you have to remove the crown first, then followed by root removal. So for mesioangular impaction, horizontal or distriangular, for all of them, the technique is different. You have to analyze the radiograph and you have to plan accordingly, because the anatomy of the root there is very high variation in the anatomy of the root. Sometimes there may be multiple root, there may be fused root, the root may be dilacerated. Furcation area may be present in the apical region or sometimes in the coronal third. So you have to plan your surgery depending on the anatomy of the tooth. Tooth division may be done using a bore and osteotome or tooth splitting forceps. In case of mesioangular impaction, when you have raised the mucopurulent flap, when you have done the buccal guttering, then it depends. If the root is conical, then you have to remove the distal part as shown in the figure. You have to section the tooth. You have to remove the distal part. Once the distal part is removed, then you can mobilize the tooth into the empty space. Okay. So the most common impaction is mesioangular impaction, where you are operating for mesioangular impaction, you have to remove the distal most part. Once the distal part is removed, you will create the space in the distal surface. So now you can apply the force distally and you can remove the remaining part. In case of horizontal impaction, again, the first thing you have to do is buccal guttering. After buccal guttering, you have to section the crown part. When the crown is sectioned, you have to remove the crown first, then followed by removal of the distal root, then followed by mesial root. Okay. In case of vertical impaction, after buccal guttering, you have to section the tooth. You have to separate the mesial root and distal root. So you have to remove the distal root first, followed by mesial root. In case of distriangular impaction, again, after buccal guttering, you have to section the crown. You have to give the osteotomy cut at the level of cement enamel junction. Then you have to remove the crown. After crown is removed, again you can remove the root, first mesial or distal, followed by the other one. There is something called lateral definition technique, though it is not followed nowadays, but they may ask the question, so you must know what is this. There is something called as prophylactic odontomy. Previously, it was thought that if we don't remove the third molar tooth before, then it will create prolonged lateral. It will cause pericoronitis. It may cause angle fracture. It may damage the second molar tooth. So it was thought that it has to be removed at the age of 9 to 16 years. That is known as prophylactic odontomy. But this concept is not followed nowadays. That is old technique. So while remove the third molar tooth, when it is still it has not erupted completely, that's process known as lateral definition technique. So it's indicated for removal of unerupted third molars in the age group of 9 to 16 years. In this case, a modified S-shaped incision is made from the retromolar fossa across the external oblique ridge. Okay, as you can see in the first figure, this is a incision line. It is a modified S-shaped incision. After that, buccal cortical plate is trephinated over the third molar crypt. After this trephination, bore is used to make a vertical cuts anteriorly and posteriorly, and the buccal bone is removed. Once the buccal bone is removed, then you can remove the tooth board of third molar. That's in a lateral definition technique. It is old technique. It is not used nowadays. It is only of historical importance. Another technique is split bone or lingual split technique. It was given by Sir William Kelsey-Fry in 1933. It is also not used nowadays. It is only of historical importance, but sometimes they ask the question, so you must know. In this case also, it is only indicated if the tooth is present more lingually and it is more superficial. In case of deep impaction, you can do the lingual split technique or split bone technique. Again, the incision given on the buccal surface, similar to the Watts incision. You have to start the incision from the buccal surface. You have to reach the distal buccal lining of the second molar. Then you have to do the clavicular incision, limb B, followed by limb C or distal incision. Once you have reached the mucoperiosteal flap, now you have the differences. Now you have to give the vertical cut with chisel and mallet on the mesial surface of 8 or distal to 7. Then followed by, once you have given the vertical, then you have to give the again horizontal cut. The length of the vertical cut is about 5 mm. After giving the vertical cut, you have to again do the horizontal cut. You have to remove the buccal bone. Once the buccal bone is removed, now you have to remove the lingual bone as well. That's the difference from other technique. We never remove the lingual bone using board or in any method. Just we do the buccal cutting, we remove the buccal bone, then you start sectioning the root. We never enter into the lingual surface, because you may, if you do any instrumentation in the lingual surface, you may damage the lingual nerve, so you have to be careful. But in this technique, the lingual bone is also removed. The distal lingual bone is splitted and it is removed. Once the lingual bone is removed, now you can elevate the tooth and you can extract accordingly. So sometimes they may ask what is lingual split technique or what is William Kelsey-Fry technique. It is the process used to remove the impacted horner, which is lingually placed. Now moving to maxillary third molars, classification impacted maxillary third molar is similar to the mandibular third molar. So it may be mesioangular impaction, distoangular impaction, vertical impaction, horizontal impaction. It may be buccoangular, linguoangular, and inverted. Okay. In case of mandible, it's just to remove as mesioangular, but in case of maxilla, it's just opposite. Mesioangular impaction is difficult to remove. The easiest to remove is distoangular, because the bone is not present distal to maxillary tuberosity. There is presence of pterygopalatine fossa. There is empty space, so it's easy to remove the impacted horner root is distally angulated. So depending on the position of the tooth, relative depth of the impacted maxillary horner in bone, it is again classified as position A, position B, and position C. In case of position A, occlusal level of 7 and 8 it is at the same level. In case of position B, the occlusal level of 8 is just above the occlusal level of 7 and it is above the cemental ion junction. So the occlusal level of 8 is present between the occlusal surface of 7 and the cemental ion junction of second molar tooth. Again, in case of position C, the occlusal level of impacted third molar is present above the cemental ion junction of second molar. It's similar to mandibular third molar. Another classification based on relationship of the impacted maxillary third molar to the maxillary sinus. Again, it is of two types: sinus approximation and no sinus approximation. In case of sinus approximation, no bone or thin partition of bone between the impacted maxillary third molar and the maxillary sinus is present, and it is known as maxillary sinus approximation. So either very thin, paper-thin bone is present just above the apical region of the maxillary third molar, or there is no any bone present in the apical third. It is directly continuous with its continuation with the maxillary sinus. This condition is a sinus approximation, and the problem with such impacted tooth is you may create oroantral communication. In case of no sinus approximation, 2 mm or more of bone between the impacted maxillary third molar and the maxillary sinus, known as no maxillary sinus approximation. If at least 2 mm bone thickness is present between the root of the third molar and the maxillary sinus is present, then it is known as no sinus approximation. So the thickness of bone should be either 2 mm or more. Again, the removal of maxillary third molar, it's similar to the mandibular third molar. Okay, you have to raise the mucoperiosteal flap. Here you have to give the releasing incision. The problem while removing the maxillary third molar is the presence of buccal fat pad. Buccal fat pad may herniate into the surgical site. Another difference from the mandibular third molar is you have to do buccal guttering in case of mandible using either ball or chisel mallet, but in case of maxilla, the maxilla has very thin porous cancellous bone, so you can even remove the bone using a periosteal. It is very thin bone. Okay. After raising the mucoperiostral flap, you have to remove the buccal bone. Then you can luxate the tooth and you can remove easily. If the bone is, if the bone is more corticated, if it is hard, then you can use the straight handpiece and ball. And remember, whenever you are removing an impacted tooth, when you are removing the bone, never use a rotor, because it works on high pressure. There is a high air pressure, so it may lead to a tissue emphysema. A complication of removal of impacted teeth intraoperatively during incision, you may damage the injury to. You may damage the facial artery, because the facial artery is just present at the lower border of the mandible, just anterior to the attachment of masseter muscle. It crosses the facial artery, crosses the lower border of mandible, anterior to the attachment of masseter muscle. Okay, and it goes superiorly and divides into superior level artery, inferior level artery, okay, angular artery. So whenever you are giving the sulcus incision in the sulcus area, if your blade slips, it may cut the facial artery. And the problem with the arterial bleeding is it's very difficult to control the bleeding, because there is pulsatile bleeding, projectile bleeding is there, and you can't control the bleeding using pressure or anything. If by chance you have cut the facial artery, you have to ligate the artery. You have to approach the artery through submandibular incision. You have to give the submandibular incision, explore the salivary gland, then you have to explore the facial artery, then you have to ligate it. So be careful. Another problem is injury to lingual nerve. Whenever you are doing an instrumentation on the lingual surface, then you'll damage the lingual nerve. So never try to do an instrumentation on the lingual surface. Whenever you are splitting the tooth, don't reach till the lingual surface of the tooth. You have to at least, if you have got more than 50% of the tooth buccolingually, then you can split it with using a straight elevator. Another problem is hemorrhage. So whenever you are doing the surgery, try to raise the mucoperiostral flap properly. If you breach the periosteum, mucoperiostrum, there will be soft tissue bleeding, so the visibility will be reduced. Another problem is there will be oozing of blood from the bone as well. And the most important thing, you have to take the careful history. Patient may have been taking warfarin or oral anticoagulants for any cardiac reason, or patient may have the history of a stroke. So such patient usually take the warfarin. Warfarin is oral anticoagulants. Okay. Also, the patient may have been taking either aspirin or clopidogrel. In such cases, you have to do medical consultation and you have to stop the drugs before 7 days. Then you have to proceed with the surgery. Once the surgery is completed, again you have to restart those blood thinner. No, let's say if patient is taking warfarin and his INR is, let's say, 3, then what will he do? We'll proceed with simple extraction. Let's say no, it's not impaction. If normal extraction, whether you will do extraction or not. Patient is taking oral anticoagulants. Okay, his target INR is 3. Okay, normal INR level is 0.7 to 1.2. Okay, its INR is 3. Due to cardiac reason, he is taking warfarin. Now, what will he do? Will do normal extraction or not? Whether will you stop the warfarin yourself, or will do medical consultation, cardiology consultation, or you extract the things? So there are two schools of thought. Okay, you can do anything. There is something called as bridging therapy, and there is non-bridging therapy. The traditional method is bridging therapy, in which what we do, we stop the warfarin, okay, and then we have to start the low molecular weight heparin. That is also called as collection. If the patient weight is less than 40 kg, then you can give 0.4 mg subcutaneously. If the weight of the patient is more than 40 kg, then you have to give 0.6 mg subcutaneously. Or another option is you have to infuse the low molecular weight heparin, because the heparin is soft acting blood thinner. Warfarin has more long half-life. Okay, so you have to stop the warfarin and start the low molecular weight heparin, or you have to start the Clexane, and you have to check the INR. Once you have stopped the warfarin, the INR will fall down. So you have to check the INR at least once daily, or you can check the INR BD morning and evening. Once the INR is below 1.5, then you can proceed with the extraction. Then on day of extraction, you have to stop the Clexane or low molecular weight heparin. Okay, in the morning you have to stop the drug, then you can proceed with the extraction. Once the extraction is done, okay, when the INR is less than 1.5, then you have to start again both the drug warfarin as well as low molecular weight heparin. Again, you have to check the INR, okay, morning and evening. Now, once you have started the warfarin, the INR level will again rise. Okay, it will rise to 1.8 to 2.53. Once the target INR is reached, if it's 3, then you have to stop the low molecular weight heparin or Clexane, and you can continue with the warfarin. That is called as bridging therapy, and it is a traditional method or conventional technique. For that, you can either do medicine consultation or cardiology consultation. It's better to do cardiology consultation, because the problem is if you stop the warfarin, the clot may form in the body anywhere, and it may get lost within the heart muscle, within the vessels of the heart, or it may get lost in the brain. So it will be a problematic. So it's better to be in safe side. It's better to do either cardiology consultation. If the cardiologist is not available, you can do consultation with the medicine. So if some complications happen, you will be on safe side. Okay. Yeah, and I have told, if you stop the warfarin broad thinner, the other complication may happen, because the clot may form and it will lead to a stroke, or it may lead to MI or some problems, some complications. So the next option is, next treatment is, there is something called as non-bridging therapy. Okay, the problem is if you don't stop the warfarin, only the chances of bleeding is high. Okay, there is no any other complications. So when you are planning to do extraction, let's continue the warfarin. You can extract the tooth, just extract the tooth, put some gel foam or surgical within the socket, and put suture, where no matters whether it is non-surgical extraction or close extraction, whether it is mobile tooth, that doesn't matter. Just put the surgical or gel foam, do suturing, and give pressure pack, and you have to observe the patient. The bleeding may happens. Okay, you have to control the bleeding by local measures. You can use adrenaline, so gauze piece. You can also apply tranexamic acid, but in most of the bleeding, using local pressure, you can control the bleeding. And you have to observe the patient for at least 1 to 2 days. Once the bleeding is stopped, you can discharge. So that is known as non-bridging therapy. So bridging therapy is a traditional method, old technique. Non-bridging therapy is the recent technique. And it is said that using non-bridging therapy, you can extract the tooth even though INR is up to 4. Because we came across one of the complications when we were doing residency in the India. What happens when we stop the warfarin and patient was admitted? We are planning to do the extraction on the day before, on 1 day before surgery. When we sent the patient for cardiology consultation, there was one clot within the heart. There was a stock valve, so they have to do immediate cardiothoracic surgery. So you don't know when the complication happens. Okay, so you have two options. Either you do cardiology consultation or medicine consultation and stop the drug. The chances of stock valve is very high. The clot may form. Another option is don't stop the drug, continue with your surgery. Just put gel foam or surgical, apply a suture, and put pressure pack. Observe for 1 to 2 days. You have to admit the patient, then you can discharge. There might be some bleeding, but no need to worry. As you know, even though if the 15% of the blood has been lost from our body, there will be no any physiological problem. 15% means how much? About 750 ml. And don't worry, there will never be such a huge bleeding from the extraction circuit. We will never lose 750 ml of blood. Okay. So there would not be any systemic complications. Patient is safe. Just the problem is there will be some local bleeding, that's all. So in case of patient, if there is a history of bleeding, then you can do either bridging therapy or non-bridging therapy. Now next Complication is intraoperatively during bone removal, you may damage the second molar tooth, especially if there is any restoration, if there is crown, if the crown is, if patient has put some metal ceramic crown or prosthesis. In 7, the chances of its dislodgement is very high, because whenever you are using elevator and the major buccal line angle of the 8, you may damage the restoration of 7. You may damage the crown. Next is slipping a bore into the soft tissue and causing injury. Extraoral mucosal bond. What happens whenever you are using a straight handpiece micromotor? There will be, if you are doing the surgery for long duration, the micromotor handpiece may get heated and it may cause formal bond or bone injury over the lips area. So that's also you have to take care. Fracture of the mandible when using chisel and mallet. If you apply excessive force while using chisel mallet, you may cause angle fracture of the mandible. There may be chances of cutaneous emphysema, so you should not use a rotor or high pressure handpiece. During elevation of tooth removal, there is luxation of neighboring tooth or fracture restoration, especially 7 second molar gets luxated, or if there is any restoration, you may fracture those restoration. There may be chances of soft tissue injury due to slippage of elevator, injury to inferior neurovascular bundle if the molar is deep, if it is associated with inferior canal, then you may damage the neurovascular bundle. There may be chances of fracture mandible. Impacted tooth is commonly associated with angle fractures, so you have to be careful. Never apply excessive force while removing the impacted tooth. Forcing the tooth into the submural space or inferior nerve canal, breakage of instrument, or PMJ dislocation. Post-operative complication can be immediately, it may be hemorrhage, there will be pain, so you have to prescribe the medication. Okay, whenever you have done any extraction or impaction, when will you tell the patient to take the medications? What is the ideal time to take the medications? Patient has to take the painkiller before the effect of anesthesia wear off. Okay, so when you are applied the gauze pack, just after removing the gauze pack, you should most instruct the patient to take the painkiller. Most commonly, we prefer ibuprofen and paracetamol for pain control. So patient has to take those medication before the effect of anesthesia wear off. So what is the duration of local anesthesia? Yeah, it's 60 minutes in pulp and in soft tissue. Lignocaine adrenaline, it has its effect for 60 minutes in pulp and about 3 to 5 hours in soft tissue. Okay, so you have to instruct the patient to take painkiller just after removing the gauze pack, so that the effect of anesthesia, when the effect of anesthesia is gone, there will mostly have effect of oral medications. Another complication can be edema or swelling. Most of the, whenever we are doing the surgery, formula surgery, in most of the patient there will be edema, there will be swelling, and swelling may increase till 3 days. After 3 days, it decreases and it will be normal in 7 days. The delayed complication can be alveolitis, there may be dry socket, there may be infection or trismus. Most of the time, whenever you give the inferior nerve block, the medial due to trauma to the medial pterygoid muscles, there will be fibrosis, and patient may have trismus. So when there is hemorrhage can be prevented by using good surgical techniques, minimize trauma, avoid tears of flap. If you tear the flap, there will be soft tissue bleeding. Most effective measure to achieve hemostasis is via moist gauze pressure over the wound. That is the best technique to control the bleeding from the extraction socket. And most of the time, you don't have to give any systemic drugs to control the bleeding. Application of topical thrombin on gel form into the socket and over suturing. Other hemostatic measures are, you can use oxidized cellulose that is available in the market as Oxycell or Surgicel, or microfibrillated collagen. Patients with acquired congenital coagulopathy may need blood product replacement. You may have to do blood transfusion if the clotting factor is not sufficient. Other complication can be nerve injury. 0.6 to 5% of all molar surgeries are involved with nerve damage, of which 0.2% is irreversible. So in case of inferior nerve, immediate disturbance is present in 4 to 5% of the patient, and permanent disturbance is present in less than 1%. In case of lingual nerve, immediate complication is present in 0.2 to 22% cases and permanent in 0.2%. So chances of lingual nerve damage is high as compared to inferior nerve. So 96% of inferior nerve injuries show spontaneous recovery within 9 months, better than lingual nerve, which is about 87%. Beyond 2 years, recovery is unlikely. If there is some paresthesia after removal of the third nerve, if the patient has not get his sensation till 2 years, then the recovery is unlikely to be permanent. The chances of inferior nerve damage recovery is comparatively high as compared to lingual nerve because the inferior nerve is present within the bony canal. So chances of reunion is very high. But in case of lingual nerve, it is present within the soft tissue. The chances of reunion of lingual nerve is low. Now, role of steroid impaction, whether we use steroid in case of impaction surgery or not, whether it is indicated or not. If you use a steroid, the post-operative swelling will be reduced, post-operative pain will be reduced. Okay, there will be less edematous fluid, and the recovery time will also be decreased. But the problem with steroid is, as it is immunosuppressive agent, so the chances of infection is high. So it depends on surgeon. Some of them may use the steroids, some of them may use for stat, single dose, some use for 3 days, some of them use for 5 days, and some of them do not prefer. So both school of thought is correct. Whether you use or steroid or not, that depends on you. Okay. The advantage of using a steroid is there will post-operative swelling will be decreased, post-operative pain will be decreased, healing time will be less, and the disadvantage of a steroid is as it is immunosuppressive, chances of infection is increased if you use the steroid. So whenever there is infection, never use a steroid. Especially in case of a space infection, steroids, you must not use the steroid. So overall conclusion is, in case of steroid, whenever you are doing any surgery, impaction surgery, if you have removed the bone, chances of swelling is high. You can give the stat single dose of steroids immediately after surgery, either intravenous or intramuscular. Intravenous dexamethasone is more effective as compared to intramuscular. So if you give the stat dose, single dose, the chances of swelling also decrease, and if you are given only a single dose, the chances of infection is not so high. So it depends on you whether you use or not. Both the school of thought is correct. It has both advantages as well as disadvantages. What we do is, immediately after impaction surgery, we give intravenous dexamethasone 8 mg IV stat. That's all. Single dose. That is for impaction therapy. And whenever we are doing the major surgery in OT, operation theater, in case of operation, whenever you do any surgery in the operation theater, we use a steroid for 3 days. Dexamethasone 8 mg IV TDS for 3 days, because in case of major surgery, the chances of swelling is very high. So in such cases, we don't take risk. We give antibiotic as well as a steroid for 3 days. Now, post-operative instruction is pressure packing, ice fomentation, avoid hot and hard food, oral hygiene maintenance, warm saline mouth rinse after 24 hours, antibiotic analgesics. I think most of you are knowing these things. Okay, pressure packing is given for how much time? 40 minutes, 45 minutes, 10 minutes, 1 hour?
30 minutes.
Why 40 minutes? Why you have to apply the pressure packing for 30 minutes? What is the reason? Why only 30 minutes? The answer is correct. It's 30 to 45 minutes. But why? What is the reason? What is bleeding time and clotting time? BT in CT normal value is 2 to 8 minutes, right? It's not more than 8 minutes. The clot is found within 8 minutes. Then why have to apply pressure packing for 30 minutes or 45 minutes? There is something called as factor 13, fibrin stabilizing factor. Even though the clot is formed within 5 to 8 minutes, the normal value is 2 to 8 minutes. The clot is not stable yet, okay? It may dislodge. So there is something called fibrin stabilizing factor. For the fibrin stabilizing factor to act, it takes minimum 40 minutes to stabilize the clot. Fibrin stabilizing factor is not activated till 30 minutes. It takes about 30 to 45 minutes to stabilize the clot. In fact, fibrin stabilizing factor is clotting factor 13. Okay. Next is ice fermentation. Ice fermentation is advised to prevent bleeding. Avoid hot and hard food, oral hygiene maintenance, non-saline after 24 hours, and antibiotics and analgesics. So in case of normal extraction, whether we prescribe antibiotics or not. Yep. In all the cases, always. So antibiotic should not be prescribed in all the cases. Okay, only when there is, if there is an infection, if the lymph node is palpable tender, if it is a space infection, then only you have to prescribe the antibiotics. The problem with antibiotics, if you prescribe antibiotic for all the extraction patient, the antibiotic will not work. They may develop resistance. And once they develop the resistance, the problem is whenever there is a space infection, there is Brug's angina, or there is some space infection, the antibiotic will not work, and there will be the complication will be very high. So you should not prescribe antibiotics until and unless there is a space infection or there is involvement of lymph node. In case of normal extraction, you don't have to prescribe the antibiotics. Just painkiller, analgesics, and mouthwash is sufficient. Conclusion: many advantages, few disadvantages. Stick to protocol to have a good result.